Welcome everyone. Let me introduce my PhD topic, which is improving the success rate in the surgery of chronic mid-ear diseases. My name is Kata Illés, and I'm currently working in the department of Laryngology, head and neck surgery in the Bajcsy-Zsilinszky Hospital next to my PhD studies. My vision is the clinicians use the most effective therapeutic options in the field of mid-ear surgery, and my mission is to investigate the therapeutic options and create high-level evidence. You can see two research I am currently working on to achieve my goals. First one is the effectiveness of the mastoid obliteration in the cholesteatoma surgery compared to the canal wall-up mastoidectomy, and this has been started in September. About the background. The cholesteatoma is a destructive disease, and it originates from the tympanic membrane towards the mastoid cavity. Its incidence rate is 3 to 12 per thousand population, and without the surgery it can cause serious life-threatening complications, and the treatment is always surgical. The recurrence rate is 5 to 35%. And there is a conventional method called canal wall-up technique, where we keep the external auditory canal intact and empty the mastoid ball. And there is another option, the mastoid obliteration, when we fill the mastoid ball with bone or muscle tissue. Our aim to evaluate the effectiveness of the mastoid obliteration. Because we think the mastoid obliteration could reduce the recurrent and residual disease compared to the conventional method. Here you can see the PICO framework. The patients are who underwent mastoid surgery. The intervention is the mastoid obliteration, and the comparison, the canal wall up without obliteration. The outcome are the recurrency and residual rates, and the secondary outcomes are the hearing results, quality of life, complication rate, and operation time. The systematic search was conducted on 4 databases in November with this search key. In the beginning, we have around 5,000 articles, and in the end, we found 11 articles eligible to our research. Here is the first result about recurrent and residual disease. We found 7 articles eligible, and among these articles, the heterogeneity is 67%. That's considered moderate. These are articles all retrospective cohort studies, and some differences can cause this kind of heterogeneity. The main odds ratio is 0.45. That means the mastoid obliteration could reduce the recurrent residual diseases with 55%. The confidence interval is narrow and the pooled effective is low, so we can say that outcome is significant. Here there is another outcome about a subgroup analysis on mastoid obliteration with bone or bone replacement material, because it doesn't change its size over time, unlike the muscle. For this subgroup, we found only 4 articles eligible, and therefore the heterogeneity raised for 80%. The overall odds ratio here is almost the same, 0.46. The confidence interval also narrow, and the pooled effect P is also low, so we can say the bone and bone replacement material a good material for doing the obliteration. And here you can see the strengths and limitations of the study. This is the first comprehensive study on this topic, and more than 2,000 patient data were assessed. However, we could only use retrospective cohort studies, and there is a heterogeneity regarding the material used for obliteration and the surgical technique. And according to the Rubin's I tool, the risk of bias is high. Here you can see the other outcomes where we couldn't do quantitative analysis, only qualitative. The first one is the hearing results, where we didn't find any clinically relevant difference, and so in the complication rates and the quality of life. However, there is one article which reported on the duration of the surgery, and it says the mastoid obliteration elongates the operation time with 60%. And about the conclusion from the quantitative synthesis, the mastoid obliteration seems a safe and effective method to reduce the reoperation. However, further studies are needed because of the quality of the results. And the quantitative analysis says the mastoid obliteration elongates the operation time, but in other fields it's comparable with the canal wall-up technique. And implication for the practice, Routinely applied mastoid obliteration could decrease the number of reoperation with 138 patients per 1,000 patients. However, the further the mentioned reasons, there is a need for randomized control trials with the following criteria. The cholesteatoma should be staged with the European Association Otology and Neurotology, with Japanese Otology Association joint consent statement, and verified by the CT scan. They should compare the canal wall up with the bony obliteration, and the comparison they should use the canal wall up technique. And we recommend these outcomes for measurement. And the second project is the predictive factors of a type 1 tympanoplasty, which has started in October 2021. The type 1 tympanoplasty is a surgical procedure performed to repair the perforated tympanic membrane without the need to reconstruct the ossicles. The prevalence rate of the disease is 9 per 1,000 population, according to a German study from 2008. The success rate is around 70%, however, it can be even 40 or 90%. And there are various influencing factors that has an impact on the outcome, and we would like to evaluate the value of the factors and identify the most correlating ones. Here you can see the PECO framework and the clinical question, that how can we predict the outcome of the type 1 tympanoplasty. We think these listed exposures are important factors based on a preliminary research, but maybe this list can be changed. And the main outcome is the success rate, and the secondary is the hearing gain. We conducted the systematic search on 3 databases on November with this simple search key, and we have more than 15,000 articles, and right now we are doing the full text selection, and we have preliminary search result. We found 51 articles eligible, and we are still working on to get an access from 38 articles. And here you can see the 2 projects again with the planned submission date. And I would like to thank you for your attention with this quote.
Thank you very much for your presentation. And my question is connected to your first topic. And I want to ask that, do you use this mastoid obliteration treatment in your clinic, for example? Is it possible to use it?
Yes. Yes, we are. And actually in this week there is going to be 2.
It sounds great, because it seems like that it is a better treatment for the patients. And do you think it needs more time and money, for example, or is there any problem to put it in the...
elongate the operation time, definitely. And yes, you have to collect some bone tissue and put it there, and you have to buy a special machine for the collection, but it's not that cost so much. So actually it's pretty easy to do if you are starting to.
So you have the machines and everything what you need for this kind of treatment?
Yeah, we are doing this, yeah.
It's great. Thank you very much.
Thank you for your presentation. My question is that is there any exclusion criteria for this mastoid obliteration? So is there any case when you cannot perform it?
Yes, when the disease is too severe and extended to the bone structure, you have to do another approach, and more radical one.
Thank you.
Thank you very much for your presentation. May I ask you to go back to your last topic, the last systematic review, because you plan to measure here a lot of different exposure, and I guess in the outcome there will be a lot of different way how they express these exposures, not the all. What is your strategy? How do you plan to pool the very different outcomes together in the end?
The outcome will be the same, the success rate after 1 year, and we would like to do for each exposure a statistic, and after see where was a significance.
You will measure just differently.
Yes.
Thank you.
Thank you for your presentation as well. Just a quick question. what kind of bone samples are appropriate or acceptable for this kind of procedures?
During the surgery, we use a drill, and the drill causes some chips, bone chips, and we're collecting them and separate from the blood and replace to the mastoid ball with antibiotic.
Thank you.
Maybe I can ask that when you compare two types of intervention, independently of this investigation, you included the duration of the operation. This is one point. The overall price can be another point.
Yes, it can be.
Why not?
Yes.